Yes, the next move is determinants of myocardial performance. Now, what are the determinants of myocardial performance? Let's first list them. We have the preload, afterload, inotropic state, and then heart rate, and then others like electrolyte, balance like potassium, calcium. Then another is sympathetic, that is autonomic, nervous system, that is sympathetic or parasympathetic discharge. Yes, like these ones. These are the major determinants of myocardial performance. So we are going to see one by one and how it will affect. This is the most important thing in cardiology, that is in managing so many heart conditions or cardiovascular disorders, including heart failure, cardiogenic shock, now CAD stable, CAD, that is MI. All these ones, their management depends on your understanding of this, and then understanding of this physiology, and then its clinical applications. One of the most important concepts in cardiology, there are these two, actually not two but four. Preload, afterload, inotropic state, and then heart rate. Because this, in clinical practice, this is what they play with, either preload or afterload, inotropic state, or heart rate. And the heart rate. So we go with our first term, and that is going to be preload. So what is preload? Preload, that is the force or the amount, in simple terms, the amount of blood in the ventricle at the end diastole. How much blood is in the ventricle, like LV, at end diastole. This is preload. The major determinant of preload is going to be determined by venous return. Determined by venous return. So if a lot of blood is coming back to the heart through the great veins, the preload will be high. So this one you can also say, like in bracket, arterial pressures. This is in bracket because there are so many determinants of arterial pressures, like MR. Yes, so venous return determines the preload. There's nothing much about preload. So how do we measure the preload? Preload is like non-invasively we measure from with echocardiography, that is LVEDP or EDV. So from our last topic, it was preload is the same as LVEDV. What is in the ventricle just before the contraction starts. I won't give the normals because they change based on whether female or male. But it shouldn't go past 160, at least 160 ml. It shouldn't go. If it's more than that, it means that chamber is dilated and it is accommodating excess amount of blood. Either it is failing, like systolic failure, or there are valvular diseases like regurgitations or stenosis, and it is decompensating. So this is preload. So how is preload going to affect myocardial performance? Like what is there and what and how the heart will react. So there is this guy, Frank Starling, and his friends. Frank Starling mechanism. Yeah, like Frank Starling mechanism. Frank Starling mechanism, it states the greater the heart muscle, myocardium is stretched, during feeding, the stronger the force of contraction, or the greater the force of contraction. The greater the force of contraction, that is up to a certain limit. This one is not limitless. There is a limit that beyond which now the force of contraction reduces. We are going to look at the mechanism running the Frank Starling law, the Frank Starling law. What is? So the greater the blood in the ventricle at end diastole, that is, it translates into stretch. We have something called resting diastolic length of the myocardium. The greater the resting length, the more the force of contraction. If the resting length is short, the contraction is not going to be strong. Yeah, the contraction will not be strong. Why? Because maximal force depends on the amount of cross bridges. That is between myosin and actin during the threading filaments theory. Like myosin is attached to actin, and then that is a cross bridge. So the number of those cross bridges determine the force of contraction. If they are more, the more the cross bridges, the stronger the force generated. So if a muscle is stretched, you are increasing the number of cross bridges. If you stretch it, you are increasing the number of cross bridges. And then the more force that a muscle, that is the myocardium, can generate. If it is short, the number of cross bridges formed, they are small or they are few. That is, it translates into a small force generated. But up to a certain limit, it is limited that at a certain limit, maybe around 160, the limit which we talked about here, can be maybe 160 ml, beyond which the force reduces. Why does it reduce after a certain limit? Because of now malformation. The actin and myosin, they are so stretched that now they go far apart, because the myosin and actin are pulled far apart. The number of cross bridges again decreases, reducing the number of cross bridges. So this is what rules. So this one, Frank Starling mechanism, is one of the intrinsic. It is this one. It is intrinsic regulation of heart pumping, just by the amount of blood which is there. If it is less, the force of contraction is reduced. If it is more, the force of contraction is less, is increased up to a certain limit, where or beyond which the force of contraction decreases. And this happens in decompensation. In decompensation, most of the time, decompensated heart failure, like decompensated hypertensive heart disease, decompensated hypertrophic cardiomyopathy or dilated cardiomyopathy. So it starts decreasing, or decompensated valvular diseases like regurgitation and stenosis. That is aortic stenosis, aortic regurgitation. So this is Frank Starling forces, and this is how preload is going to affect myocardial performance. We can even draw a graph. There are graphs of resting length, and then at a certain afterload, resting length at a certain afterload, and then the force of contraction or force generation capacity. We can see that graph. So these are our curves. They are reflecting velocity of contraction and then force generation. There are three curves that we are looking at, and then at a fixed afterload. A fixed afterload can be, remember, afterload is like systolic pressure, maybe like aortic systolic pressure, like around 120. So at a fixed afterload, that is 1.5, not 2, 1.5 here, the velocity of contraction. So what is velocity of contraction? Is how fast a muscle can generate force. How fast a muscle can generate force. If you fix the afterload at 1.5 and then you leave, you change the length. See, the graph is of changing length due to changes in preload. Changing length due to changes in preload. If you fix the afterload at 1.5 and then change the length, alter the amount, the preload that comes, the amount of blood that comes to the heart, this is what you're going to get. At a very short length, here we have fixed, these are 3 curves. So we have, let's first label them. Labeling them. This one is long resting length. This one is intermediate or normal resting length or median resting length, and then this one is the short resting length. This is how we label them. So at a very short resting length, see, the velocity of contraction is very less. Now, velocity of contraction decreases with an increase in afterload. We first clear the concepts. Velocity of contraction, this is general physiology. Decreases with an increase in afterload. But also at fixed afterload, velocity of contraction increases with increasing length. This is what we see. This is what we are seeing. This last part is what we are seeing here. This is the velocity of contraction at intermediate or median length. The velocity is a bit high. It shows how fast the muscle can generate force, how fast or the lengthening, the contraction happens. And then at long length, see where the velocity is. We have fixed the afterload at 1.5. So in a normal subject whose systolic BP, is constant, like around 120 millimeters of mercury, increase in preload increases the force of contraction, because here it is a fixed afterload. Normal BP, fixed afterload at 120 systolic BP, aortic systolic BP. Increasing the preload, the amount of blood that enters LV via LA, it will increase the force of contraction up to a certain limit, maybe 150 or 160, until when the force starts decreasing. And we shall see why it decreases when you look at Laplace's rule, or law. So this is velocity and length and force with changing length. Another one is this is preload. This is how it is going to affect what? Myocardial performance. So this Frank-Starling mechanism, it is an intrinsic way of regulating heart function. Intrinsic way of regulating heart function. The more, like if a normal person consumes a lot of fluid, if a normal person consumes a lot of fluid with a normal heart, and maybe blood volume increases, maybe from maybe he had 6 liters and then consumes 2 liters a day with no urine output, and it becomes 8 liters. That heart can accommodate that amount of blood by increasing the force. So even the pressure at which it is, the systolic pressure can also increase, maybe from 120 to around 130 with an increase in blood volume, because the stock volume has increased depending on the input or the inflow, depending on the venous return. Even with exercise, because like running, because muscles of the lower limbs, they are working, so they are acting as pump to increase the amount of venous return to the heart. So with that also a lot of blood comes in and it has to be pumped out, but still with Starling forces or Frank-Starling mechanism, it is acting. There are other mechanisms that act, but also it is also plays a role, like doing exercise, in acute, like maybe regurgitations, acute regurgitation before decompensation. The heart tries, the mechanism tries to act, but because there is no adaptation, there is no time to adapt, that's why it fails very fast, because the volume is too much, the heart cannot dilate to accommodate, no. But it tries. This mechanism is always there to save. So the next is it. One was preload and another one is afterload. So if preload is low, stroke volume is also going to be low, because the heart is not going to work so hard to push that little blood which is there, no. Because there is maximal force, a certain length where maximal force is generated, below which submaximal forces are generated, and beyond which, again, submaximal forces are generated. There is an optimum length where the myocardium works well. So, and if we go back to this volume I put somewhere here, 150 to 160, or maybe 90 to 150 or 160, that is the minimum, that is the volume of blood that can generate that optimal length. If it becomes 200 ml, that is too much. It will stretch the myocardium and then reducing the force. If it is too less, still that is not optimal for heart function. And that's why these patients come with stenosis. They come still with symptoms of heart failure, and those ones still with overload, fluid overload, still they come with symptoms of heart failure. But the mechanisms are different. This one's too much stress, and here no stress. No stretch, the stretch is not there, the heart is just there. So coming from a small distance to contract, the force is not enough. Yeah, the next is afterload. 2 is afterload. So this one is a big one, afterload. So the next one is afterload. But before, this concept of preload is used clinically always, and you hear people giving diuretics, here people, they are giving diuretics, give Lasix, give what? They are trying to reduce the preload. So that preload in those patients, it is causing a lot of stress to the myocardium, reducing the force of contraction. So if we reduce, maybe it was around 200 ml, and then we give Lasix or diuretics, and then it becomes 140, we lose. The patient will go and then pass urine so frequently, so that reduce the blood volume to 140 ml. This is one of in the optimal ranges of 90 to 160. It is between the optimal ranges, so the heart function will increase by reducing the amount of blood that comes to the chamber. But if you decrease it so low, instead of 140 and then you make it 90 or 80, it's also not good. Patient will come with symptoms. So you give diuretics and then after some time remove or stop or withhold them, and then see the response. Yeah. So afterload, the forces that the heart act against in order to push blood, in order to eject. Simple, as simple as that. The forces the heart must overcome before it ejects blood into the aorta, like in case of LV, or into pulmonary artery in case of RV. So which forces? Before ejection starts, the LV must generate a pressure equal to aortic systolic pressure. So the LV, before it ejects into aorta, it should overcome aortic pressure. It must overcome the aortic pressure. If it can't, then there is no way aortic valve will open. It cannot open. So it must overcome the aortic, the diastolic pressure, we can say diastolic pressure. If the diastolic pressure is 80, then the valve will open. And it's the diastolic pressure is 80, and then the LV pressure, once it reaches 80, aortic valve is still open. If it increases and then generates up to 90, then aortic valve open. This is how it works. So if in patients with hypertension, where the diastolic pressure is very high, maybe like 100 in the aorta, meaning the LV should generate 100 before it opens the aortic valve. That is extra work. From 80 to 100, that is extra work. That's why the diastolic pressure in hypertension, it is more dangerous than systolic pressure itself, because the LV should overcome it before the valve opens. And then there comes aortic stenosis, where the valve is very difficult to open. If the valve is very difficult to open, maybe it requires 150 millimeters of mercury pressure to open. Then the LV should generate this pressure before the valve tries to open. So that is aortic pressure or interventricular pressure. Intraventricular the pressure within the chamber, within the LV or RV. Then the next is wall stress. Determinants of the other forces that should overcome is inertia, blood inertia of blood. You know, during like a subvolumic contraction, the blood is there static, it's not moving. So for it to start to move, the LV should inject some force to make it move, and that is, we will go back and then remember what is inertia. The tendency of the body to remain in a state of rest or uniform motion until when acted upon by an external force. An external force should come in. If I'm to move this pen is static, it's not moving, it has some inertia. So for it to move, I should push it. Without pushing it, it won't move. And sometimes pushing it, if I don't want it to go this side, if I push with enough force, it will go up to there. If I want it to stop, I should put a block somewhere here. That is inertia. So during a ischemic contraction, the blood is not moving, it's there static. So the LV should generate that force to make it move. So if the amount of blood is less, the force required to overcome inertia will not be much. And in normal circumstances, those inertial forces, they are negligible. But in case where the LV EDV has increased, cases that increase LV EDV, inertial forces become significant, because this is a large amount of blood that require excessive force to move it. And that's why in most of those cases, like in cases of aneurysm, like LV apical aneurysm, or any aneurysm of the left ventricular wall, we can get clots, because that blood in the aneurysmal part, it doesn't move, it doesn't participate in moving, in being ejected. No, it stays there, and once blood stays, it clots. So we always get clots if blood stays, and it can happen in dilated cardiomyopathy where EF is very, very low, or aneurysmal left ventricular walls, or even due to MI or any other cause. Now, determinants, these are like determinants of afterload. 1, aortic pressure or interventricular pressure. 2, inertia of blood. 3 is going to be wall stress. This is a very good, very big, or a good part here. Wall stress. These 3. What is wall stress? Which is pressure or force per unit time. Per unit time. Force per unit time, wall stress. It is a very good and interesting concept. Leave alone the aortic pressure, inertia. This wall stress, most of the conditions, heart conditions, we work with wall stress to reduce it. Wall stress, which is pressure per unit time as definition, it is defined by Laplace's law. So Laplace, we are giving it a subheading, wall stress. It is pressure per unit time, defined by Laplace's law. So what is this Laplace's law? This is a good question. The exam, it can come. Also Frank Starling or mechanism comes. So you must get this one clear. So Laplace's law states that wall stress which you can give this symbol, is equaling to or directly proportional to pressure times radius over 2 thickness, defined by Laplace, where we defined each term is the wall stress itself, and then P intraventricular pressure, and then R is the radius of the cavity, and then H is the thickness of the walls. Yeah, so from here we can see that when pressure is high, or wall stress is directly proportional to pressure and radius. When pressure increases, wall stress increases. When radius increases, wall stress increases. When thickness increases, wall stress decreases. So this one has a compensatory mechanism. Laplace's law presents a compensatory mechanism. Factors that increases wall stress, conditions that increase wall stress, we need to know them. Conditions that increase wall stress. Which conditions can increase wall stress? Which condition that increase pressure? Intraventricular pressure, like aortic stenosis, systemic hypertension. These conditions are associated with increase in wall stress. And then dilatation of the cavity. Due to any cause, e.g. dilated cardiomyopathy, ischemic cardiomyopathy, ICMP, regurgitant lesions, etc. All these ones are going to cause increase in wall stress. Conditions that decrease wall stress: hypertrophy. I've told you this presents a compensatory mechanism. So hypertrophy is a compensatory mechanism to aortic stenosis, systemic hypertension. We have two types of hypertrophy. We have concentric hypertrophy and eccentric. This one is due to volume overload. Volume, that is preload, remember. Over And then this concentric is due to pressure. Pressure overload. So these two hypertrophies, they are compensatory mechanism to reduce wall stress. Why wall stress is important? Why wall stress is important? Yeah, wall stress is important clinically because it increases myocardial oxygen consumption. Myocardial oxygen consumption, wall stress, all these conditions, they increase the rate of oxygen consumption. And if the heart is not willing, cannot meet that oxygen requirement, then a mismatch is going to be there, and that's when the patient will come failing. The patient will come failing. So now let's see, because we're on myocardial performance, how is it going to see oxygen consumption? If oxygen consumption increases, and if it cannot be met, then the heart will fail. See, remember, contraction is an active process. Myocardial contraction is an active process that needs oxygen. We need ATP for contraction to happen. We also need ATP for relaxation to happen. We have calcium pumps there that you need ATP to function. So any of these, even hypertrophy, is a compensatory mechanism, but it fails. It fails after some time because of increased oxygen consumption and demand, which causes metabolic mismatch. Metabolic mismatch after some time. Metabolic mismatch is going to be there, and what will be there, the oxygen requirement is more than the oxygen supply. So if that one happens, then the force of contraction is going to reduce, because the machinery for contraction requires ATP, of which ATP cannot be met. So afterload does not directly affect the contractility. Afterload does not directly affect contractility or performance. No, it doesn't, but it influences, it determines the force generation or the force required for ejection to happen. For example, in systemic or aortic stenosis, the force that the LV requires or needs to generate before opening the valve, it is more, or it is way more, much, or it is so high that in a normal size LV, it cannot handle. But because aortic stenosis develops gradually, it starts to adapt. It will adapt. How will it adapt? It will not like hypertrophying when you go to gym and start lifting heavy weight. Remember we said like this, in these curves here, we fixed the afterload, but now here, the afterload is variable. It keeps on increasing. It keeps on increasing, like severity of AS. It keeps on increasing, or systemic hypertension. If not controlled, blood pressure keeps on rising. And that is changing preload, afterload. So whenever it happens, like for pressure overload, the muscle will hypertrophy. It will add sarcomeres in parallel, and they will become big, and that one will be concentric. The thickness of the muscle will increase. Here what we wrote, concentric hypertrophy increases, results to increase in H. Concentric hypertrophy, H increases in concentric hypertrophy. So what is the effect? If pressure, for example, pressure is a bit constant, then wall stress will decrease. Wall stress will decrease because the pressure will be distributed over a large surface area. This is what a larger muscle can generate a lot of force. But if you get a small muscle and then you put a lot of force on it, the force required is supposed to be generated from a small surface area. So even the weight, it is distributed over a small surface area. So there is no way, there is no distribution of work. But when you're many, like you have something to do, like maybe you have to move like 20 or 20 stones, you have to lift them from one place to another, and then you are 20, everyone is going to carry 1. You are many, so 1. If you carry 1 stone, will you get tired? No, you won't get tired. But if you have to carry 20 and then you are only 2, meaning each of you has to carry 10. So if you are carrying 10, you will get tired compared to the other group which carried 1. So it's the same here. If the muscle hypertrophies, the force that is required to eject blood is going to be generated from many or a large muscle. So they won't get tired. That muscle won't get tired. But if it is thin, then the force will be high, force required will be high, but also it will be generated by a small or a thin wall. So it will get tired so fast. So the heart will fade so fast. Then for volume overload, it is eccentric because the heart appears big. It dilates. So only to accommodate extra volumes of blood. And now that one will make this third component, which is this third component here, inertial forces, very significant to start moving that blood, very significant. But also, and there is no, with same or even reduced wall thickness. So stress there will be high. This one, eccentric hypertrophy, stress may be there, or stress may decrease or remain same, because here in a concentric we add sarcomeres in series, so the muscle just becomes longer, not big but longer. It elongates. And if you remember from what we had, Frank Starling's, it is different. After some point, force declines. And this is how it is going to affect. So this is why patients of hypertension, they try to control even antihypertensive medications to control the blood pressure to avoid this hypertrophy and then its decompensation phase. Aortic stenosis, you try to open it. Either you replace the valve or you you do balloon, because the patient cannot stay with that one. They will start experiencing dyspnea, like shortness of breath, and in worse conditions, chest pain. If ischemia develops from metabolic mismatch. So if you're a practicing doctor, you have to know this one, or you're in cardiology, you have to know this one. These are the basics why you give antihypertensive, why you must know the pathophysiology of the disease, and these are the pathophysiology of valvular diseases, systemic hypertension, volume overload states, etc. This. So the next component, wall stress is done. Maybe let me see if we have some graph. We don't have any graph. So the third component is inotropic state. What is the inotropic state of the heart at that time? So regardless, see, afterload, preload may be normal, but when the inotropic state of the heart is low. So what is the inotropic state of the heart? Inotropic state is force generating capacity of the heart. What is the force generating capacity of the heart? Is it capable, or there are some limiting conditions? Afterload may be normal in the normal heart, normal systolic BP, no aortic stenosis. Preload may be normal, no dilatation, no regurgitation, but inotropy. We have things or medications that decrease the inotropic capacity of the heart, and those ones that increase. So if you increase at fixed preload or afterload, force of contraction increases, or even stroke volume increases. Factors that, again, let's look at factors that increase the force generating capacity of the heart. Factors that increase force generation. 1. We have calcium. How much calcium is there? Yeah, because we said that one, calcium content. 2 is it? Second is it sympathetic or parasympathetic tone. See, this one decreases. We shouldn't even be here, because we are looking at increasing, and this one increases. All conditions where the sympathetic nervous system is activated increase the force of contraction, regardless of preload and afterload. One of them is exercise, or you give inotropic agents like dobutamine. That's what it does. It increases. Also, digoxin increases inotropic state, inotropic capacity of the heart, force generation capacity. This one, we finished it in physiology. Like the amount of calcium which is there, the higher the calcium, the more the force generated. We saw that one. Now for sympathetic for sympathetic, because in sympathetic we are releasing adrenaline and noradrenaline. That's what we are producing. So adrenaline is a beta agonist. Is a beta agonist. So when sympathetic activity is increased, adrenaline is reduced, binds the beta receptors, activate adenylyl cyclase, and cyclic AMP generated, protein kinase A is phosphorylated, and now it will phosphorylate the receptors. Which receptors? Yellow type calcium channels will be activated, and then more calcium will enter the cell. I'm going through this one because I think we finished them. More calcium will enter the cell, and now more force of contraction. Another thing that increases force of contraction or sympathetic, on sympathetic activity we have increase in heart rate. So increase in heart rate removes the inhibition of phospholamban to SACA2. When SACA2 is not inhibited, very fast it will pump calcium back into sarcoplasmic reticulum, making calcium ready for release for another contraction. So this, we're increasing force of contraction, inotropic state. If parasympathetic system is activated, it has opposite effects. The vagus nerve, if vagus nerve is activated, it will decrease heart rate and force of contraction. That is why in cardiogenic shock, when the systemic or the mean arterial pressure is very low, we should work hard not to activate the vagus nerve. We should keep it inhibited. So physiologically it will be inhibited because it will be activation of sympathetic nervous system is a mechanism to increase BP in stressful conditions, cardiogenic shock inclusive. So things that we can give in cardiogenic shock, one is noradrenaline. Noradrenaline is a vasopressor. It will increase mean systolic BP or mean arterial BP. It will increase that. But another thing we can give in combination or in addition to noradrenaline is dobutamine. Increase systemic or mean arterial pressure or will cause vasoconstriction, but we should also increase the contractility of the heart. You can put it in like it is or here, contractility. How the heart is contracting, you should increase. So adrenaline alters the contractility of the heart. It increases. If you allow vagus nerve to take over, then it will decrease the contractility. So regardless of the preload or afterload, contractility will change depending on the state or inotropic state of the heart. Stroke volume will increase with increased inotropy and will decrease with decreased inotropy. This is so simple. So far 3 inotropic state, so far 3 done, inotropic state, preload and afterload. Now the fourth one is doing very fast. Fourth one, okay, we may have a graph, simple graph. Again, for contractility we have velocity. Remember what I said in the first graph, that velocity of contraction. So what let me also put the afterload here. So again, we are fixing our afterload. The afterload is fixed. We are not changing anything at 1.5 fixed. And then we have the velocity here, and then force generation. Force generated. We have high inotropic state high inotropic state or high contractility, and then we have normal contractility, and then low contractility. So at a fixed afterload, for example, if you check the velocity, remember what I said about the velocity, like velocity of contraction, it decreases with increase in afterload, and at a fixed afterload it increases with the increase in preload, and also it increases with the increase in contractility. So at a low contractility, the velocity is low at that level. At medium or normal contractility, it is above, and then at high contractility, it's where it is. So it increases with the increase in contractility. So a patient or a person with under vagal influence or vagal tone, contractility is low. A patient under sympathetic tone, contractility is high. So this is a graph. It is very easy to understand from the graph than from the words themselves. So this graph is for effects. This is for changes in contractility. Yeah, it is for changes in contractility and length. With force generation. So that is the graph. Very simple and very clear concepts, like when you are choosing, you know, a patient with tachycardia, this one is happening, so should I remove the tachycardia or leave it? A patient with hypertrophy, can come with signs and symptoms of ischemia. Why? Because of can come with diastolic dysfunction because of ischemia, induced hypertrophy induced ischemia. You know that, and you know the mechanism behind. Next, the third one is the heart rate. Yeah, I've talked about it here, but very roughly. So we are continuing with heart rate. Very fast, nothing much to say, but contractility increases. We should know this, that contractility increases with increase in heart rate. Contractility increases with increase in heart rate. What do we have with increase in heart rate? With increasing heart rate, the diastolic time is shortened. We know that the diastolic time is shortened. So if diastolic time is shortened, then ventricular filling is disturbed. We saw this in physiology. The ventricular filling is disturbed. So what would be the effect? The effect would be the Frank-Starling mechanism would work. That if the ventricles are not fully filled, the force of contraction will reduce and thus the stroke volume. So stroke volume decreases and thus cardiac output. This we know that it can happen. But in actual sense, increase in heart rate, we need it. Like for example, under physical activity, we need the heart rate to increase. Though, are we working to decrease the cardiac output? No. Actually, with increasing heart rate, contractility increases. When contractility increases, why does it increase? We need to answer that question, why? Because of increase in intracellular calcium. A lot of calcium, so how does it increase? The rate at which calcium is brought in, the rate at which calcium is brought inside the cell increases than how it is cleared. So the effect is to increase it, but when it increases, shouldn't it be in a cytosol, in cytoplasm? No, calcium should not stay inside. It should not stay in cytoplasm. When it increases, it should be in cytoplasmic reticulum. That's where it's supposed to be. If it stays in the cytoplasm, then the muscle will never relax. As long as calcium is there, it will stay contracted. And that is what hypercalcemia can cause. Hypercalcemia can cause a very, very tagged myocardium. It stays in systole and fails to relax. We don't want that. So when increasing intracellular calcium, more importantly, in sarcoplasmic reticulum. So what happens with increase in heart rate? Phospholamban is inhibited. Phospholamban is inhibited. Due to inhibition of phospholamban, PLB. It is a regulatory protein that inhibits. So this one, when in normal heart rate, phospholamban inhibits SACA. Sarcoplasmic, endoplasmic, reticulum, calcium, ATPase. It inhibits. So when it inhibits this one, the rate calcium uptake into sarcoplasmic reticulum decreases. So this decreases the available calcium for contraction in normal states. But with tachycardia, this inhibition is removed and SACA acts at its best, pumping calcium back into sarcoplasmic reticulum. So reducing its concentration in cytosol, but also making it available for the next heartbeat. So with increase in heart rate, calcium keeps on building beat after beat, until a maximum. up to a point. It's not true that it keeps increasing forever. At 500 it's still increasing. No. Tachycardia is important, but not all tachycardias. So what is the normal range? What is the limit beyond which contractility with tachycardia decreases, or with increase in heart rate decreases? So you can write at what heart rate does contractility start decreasing? At what heart rate? In normal individuals under exercise, for example, contractility will increase until up to around maybe 150 beats per minute. Approximately 150 beats per minute. Contractility is increasing. So 140 contractility is high, 150 contractility is high, then beyond beyond 150 beats per minute, what happens? The time for calcium recycling is not enough. For calcium is no longer enough. It is no longer enough. The time for calcium recycling is no longer enough. Also, beyond 150, oxygen consumption increases. O2 O2 consumption increases, coupled with, again, reduced diastolic time. Reduce diastolic time. So all these ones, if you do these ones, from the resting heart rate to 150, CO increases, but from here, then cardiac output. With increasing heart rate, when you try to measure cardiac output, it will be decreasing because of reduction in stroke volume, but all coming from a reduction in contractility. So patients with heart failure, for example, dilated cardiomyopathy, for example, hypertrophy, for example, this mechanism is not working, and the maximum heart rate for them they need for contractility to start decreasing, it is way below 150. You may find it's around maybe 120 or even 110. So for them, it is very low. So under those circumstances, heart rate should be controlled. For example, in acute MI, with stable hemodynamics, heart rate is always controlled. It should be below 100. It should be below 100, at least 80 beats per minute. With stable hemodynamics, it should be controlled at least below 100 to avoid this, because ischemia is already there. So if you increase the heart rate, you are doing worse. The myocardium is already suffering, and then you are increasing heart rate, increasing its oxygen demand, and then you cannot supply it. Metabolic mismatch. We don't want that one. So beta blockers are always given, but in conditions where hemodynamic instability is there, like hypertension or cardiogenic shock, Then heart rate is left because it is a compensatory mechanism for hypertension to increase BP. We have seen how it increases BP. It increases stroke volume and cardiac output because of increased contractility. So we let it be, we don't tamper with it. If hemodynamically unstable. But if it's stable, then you have to decrease it. That is true for patients with heart failure. They are always taking beta blockers to decrease heart rate and also to prevent arrhythmias. And then there's patients with heart failures, again, they are given digoxin to increase calcium handling, to increase intracellular calcium. Then yeah, that is heart rate. Heart rate, increase in heart rate is so important. It's so important, but up to a certain limit, beyond which detrimental effects start coming in, and these are the detrimental effects. So clinical practice, you have to know all these ones. Like I normally attend their rounds and they be there asking you if a patient with MS, that is mitral stenosis, or like in a patient of mitral stenosis with pulmonary edema, can you give beta blockers? A patient of mitral stenosis with pulmonary edema, can you give beta blockers? And that can be the question. It is either yes or no, or they are contraindicated. Can you give beta blockers? Actually, yes. Yes, we can give beta blockers. Why? What do beta blockers do? They decrease heart rate. If heart rate is decreased, then the diastolic time is increased. So the time the valve remain open is increased. So that one increases the amount of blood that moves from LA into the LV. And now increasing force of contraction through Frank-Starling mechanism, increasing stroke volume and then cardiac output, but also relieving the LA pressures. Relieving the LA pressures. So if LA pressures are decreased, then pulmonary edema will also be decreased because there is no more congestion. Blood keeps coming. A compensatory mechanism or response, a physiological response to pulmonary edema, will cause dyspnea. What it will be? Tachycardia. So those patients with severe MS, they will come with heart rates around 130, 120. But that one, we don't need that heart rate. We need to increase the diastolic time by giving beta blockers. Those patients can be taking as much as like 100 mg BD of metoprolol, or 50 mg in the morning and 25 mg in the evening metoprolol, to decrease the heart rate, increase the diastolic time, increase the amount of blood that flow from LA into LV. At the same time, increase stroke volume, increase cardiac output, but also relieving the LA pressures. So that question, most of the time, they keep failing because they don't have this knowledge of Frank-Starling what and what happened, the pathophysiology of mitral stenosis. Yeah. Whew. So we are done with this one. I will see the next topic. Thank you.